continuing the discussion about bipolar affective disorder. I've got Professor Allan Young, an internationally renowned expert for mood disorders. Thank you, Allan, for being on my video. And if you haven't already watched the previous video where Allan explains bipolar affective disorder 1, 2, early warning signs, and many other things about the condition, please do watch it. We'll move on and talk about treatment and other things in this episode. What treatments are effective for bipolar affective disorder?
Well, that's a very good question. And when we think about treatment for bipolar disorder, we have to think about which phase of the illness we're treating. So generally, you can treat elevated mood, which is mania or hypomania. You can treat depression, and you can treat mixed states. And also there's preventative or maintenance treatment. So if we go through those, our treatments for mania are usually things like antipsychotics, which are really anti-manic in this instance, because they're effective in treating mania and hypomania, whether or not you have psychotic symptoms. And these are pretty effective. Lithium is also effective for mania, and some of the anticonvulsant mood stabilisers, valproate, carbamazepine, are also effective, but they're less commonly used. And of course, there's a big reservation about using valproate because of the effect on women's reproductive health. There was a recent worry about the effects on men's reproductive health, but that seems to not be an issue. It seems as though it doesn't really affect the dads, it's affecting the mums and the unborn child. So that's mania. The people who've got mania with depressive symptoms, we don't really know much. We do treat them with those medicines. There is one trial that suggests that there's one antipsychotic, one called asenapine, which is a bit like it's got a structure a bit like an antidepressant that might be better in people with mania with depressive symptoms, but there's not a huge amount of actual studies in that area. Now, for depression, we've got far fewer treatments, and we've got even fewer treatments in the UK and Europe, because some of the licensed treatments haven't made it across the Atlantic. So the first thing to say is that there's very, very little evidence that antidepressants, which are really antidepressants for unipolar disorder, are effective. So one, if not the biggest trial, was done by myself with colleagues in the United States and sponsored by the drug company AstraZeneca. We were looking at quetiapine, which I'll come on to talk about, and we were looking at an SSRI, paroxetine, and placebo. So quetiapine was effective for bipolar depression, but the SSRI wasn't. It did have a little bit of an effect on anxiety, but really it didn't separate from placebo. Now, there's really little other evidence about antidepressants, but they're one of the most commonly used drugs. People are worried that they may destabilize the illness, spark off highs.
I was going to ask about the switch, as they call it.
Cause rapid cycling. That was a great concern, and I think it probably does apply to some people, but not many. So I did an article about this in the American Journal. There's big evidence from databases in Denmark, where they follow everyone, that antidepressants aren't associated with any increase in mania or hypomania if you're on an anti-manic drug. So there may be a risk if you're not. In the study I just mentioned, where we treated bipolar depression 1 and 2 with paroxetine, the rate of switch was not higher than that caused by placebo. So it was about 10.5% with paroxetine and about 9.5% with placebo. Now you can see if you increase the numbers, that might become a significant difference, or it might disappear, we just don't know. But antidepressants, I don't think should be first or even second line treatments for bipolar depression. Lithium does seem to treat bipolar depression, but it's not as effective, in my view, as quetiapine. Now, I did lots of the quetiapine trials with American colleagues. Unlike the other antipsychotics available at that time, quetiapine does appear to be effective for bipolar 1, bipolar 2 depression, and for preventing return. So it treats both highs and lows, and you could actually say it's a mood stabilizer like lithium. Now, some of the old antipsychotics like haloperidol actually were bad for mood, so although haloperidol really treats mania really well, there's much more of a switch into depression afterwards. So this isn't switch into mania with antidepressants, it's a switch into depression. With the old, with the first generation drugs. And it's, my experience of this was it was very difficult to treat this. People got very stuck in the depressed phase. So that's why we favoured drugs like quetiapine and so on for treating the depression, because treating mania as well, because they were much less likely to cause the depression. Okay, so that's a bit about mania, a bit about depression. There's a slew of new atypicals, antipsychotics, which seem to have got good trial evidence for treating bipolar depression, things like lorazepam, cariprazine, this new drug that's coming out, lumaterapone. They all seem to be good, but of course they're either not available in the UK or not approved by NICE and so on in Europe or the UK for remuneration. So our use of these is very limited. Now, if we move on to maintenance, maintenance is very important because of the high likelihood of relapse. So I would say somewhere above 90% of people with bipolar disorder will have a relapse at some time. And we know the average length of time to a relapse is between 1 and 2 years. Varies in different studies, but in the best studies, I think, done by Professor Angst in Switzerland, it's about 2 years. And of course, the risk of relapse never goes down. So this is a very important point to mention, is that people can be well on maintenance treatment for a prolonged period of time, and they think they don't need treatment anymore. But as my colleague in Newcastle, Professor Jan Scott, says, you're well because of the treatment. It's not that you're well and you don't need the treatment. So maintenance treatment is the same drugs as we use to treat the acute episode. There may be a little bit of personalization with, if someone's got more of a manic picture, you might use more of an anti-manic maintenance, and if it's more depression, you might use more of a depression maintenance, but very often people are on a mixture. 50% in our review of all the literature, 50% of people on bipolar 1 who take lithium do very well with it, and that's quite striking. But also there's the possibility of psychological approaches kicking in, particularly for maintenance. So there's something called psychoeducation, which was pioneered by my friend and colleague in Barcelona, Eduard Vieta, and his colleague Francesc Colom. This was group-based. It's a series of groups where you have a education about the illness, what the illness is, the destabilizing factors, early warning signs. Our psychoeducation program here adds in other things. We talk about general aspects of physical health, we talk about sexual health, relationships, and so on and so forth. Now, this significantly reduces relapse. So this is a psychological treatment, if you will. It's also true that the group aspect seems to be more powerful than the individual. And I think that's because there's added value from having reflection from other people with bipolar. So if I say to you, don't stay up late at night, don't go on the internet, don't drink too much, you might think, well, he's just a doctor saying that. But if it's someone else saying, well, I used to do that, but when I stopped, my illness course got much better, it's much more powerful. Then there are other, what we might call bespoke treatments. So I think there is a role for other psychotherapies, but I don't think those would be first-line treatment and maintenance, but some people might do well with cognitive therapy, some people might need a family therapy approach, and some people might need other particular approaches. Neurostimulation should be mentioned. Now, the most commonly used neurostimulation method is ECT, which gets a bad press and is very unpopular, but it's very effective at treating depressive episodes. It actually also treats mania. I think ECT should be considered for severe acute episodes, yes. And other neurostimulation methods which are perhaps more broadly acceptable, like transcranial direct stimulation, TMS, they may have a role in treating episodes and in maintenance to some extent. But all of this needs to be tuned to the particular person and their needs. The other thing I should say is that we're doing trials combating the cognitive impairments in bipolar. Now we know that mood disorders is associated with cognitive impairment, problems with attention, memory, what we call executive function, which is the ability to switch, set, plan forward and so on. Now, on average, before the first episode, people with bipolar disorder are on average brighter than their matched peers, and they tend to lose a little bit of this extra cognitive reserve with every episode. Now the reason I mention this is because they miss their extra cognitive reserve terribly, but they may still not score as abnormal on the tests. If you want to do an analogy with height, if you started off at 6 foot tall and the average was 5'8", and you lost 3 inches and went down to 5'9", you'd still be above average, but you would feel you were 3 inches shorter. The same happens with cognition. Now with Professor Till Wykes and colleagues at the colleagues in Oxford, Birmingham, Newcastle and so on, we are just completing, we'll have completed early next year, a big study of cognitive remediation, which is a program to learn new skills, practice skills and so on and so forth in bipolar disorder. We did a pilot study which was actually really surprisingly effective and enhanced social functioning. Social functioning is important not only for the individual, but also impaired social functioning or psychosocial functioning is a driver of greater costs because it's related to poor employment prospects and so on. So I think we can think about treating the episodes, we can think about treating the maintenance with medication, we can think about psychoeducation, other bespoke approaches, neurostimulation when it's used, but we're maybe moving beyond the actual mood symptoms to think about cognition. And of course the last thing is that people with bipolar disorder need their physical health looked at, physical health needs looked after, because like people with schizophrenia and severe depression, they tend to die about 15 years early compared to the matched population. A small part of this excess is suicide. The vast majority is the common killers, heart disease, cancer and so on, diabetes, which just seem to hit earlier and harder in people with severe mental disorders.
That's correct. Would you, and you have touched upon it already, but would you recommend any lifestyle modifications for individuals who have this diagnosis that might help?
Yeah, absolutely. I think first of all you've got to know the illness and know yourself. There's an old psychological defense mechanism termed denial, which we're all taught about as psychiatric trainees. Very often early in the course of illness, people are prone to denial. And I've had patients, including patients who are doctors, say, I don't want to be bipolar anymore. I don't want to have to live this lifestyle. I don't want, I want to be able to go out and party till dawn, and so on and so forth. Well, that's again a bit like someone with diabetes saying, well, I want to eat cream cakes. If you eat the cream cakes and don't take your insulin, you'll have diabetic crises.
Correct.
So it's the same with bipolar disorder. So essentially it's everything that we would say for a healthy lifestyle for everyone else, avoiding triggers and so on and so forth. There's a major problem with hypersexuality during episodes, and this is particularly shameful for women. We've written about this, and of course what happens during an episode is that people can behave in a way that's totally out of character for them. Hypersexuality, having multiple partners and so on, in a way they never would when they were well. They can get sexually transmitted disease. This is going to have a devastating effect on relationships and so on, because it's very difficult to get forgiveness, really. So we need education about that and preventing that and so on. But like everything else, we need to look at the person's health in the round, really. Generally, what's good for your heart is good for your brain. So all the general health advice about diet, exercise, controlling blood pressure, that applies to our patients with bipolar disorder just as much as anyone else, and it certainly won't harm their likelihood of doing well with their condition.
I agree with you. I also advise people to have a structure and routine.
Yes. Yeah.
Same wake up time, same sleep time, same lunch time, because the brain responds better if it knows there's a structure and a routine.
Well, that's absolutely right. There's lots of research interest from colleagues in this country, Europe, the US and so on, about the role of circadian rhythms and daily rhythms being fundamental to bipolar. I certainly think they get disrupted in episodes, but to my mind, cause and effect still isn't shown. But there's no doubt that doing what you say is actually good advice for people with bipolar disorder.
Mm. There is one question that was put on my YouTube community forum, and I'm going to read it verbatim, Alan. Are there any cases heard of where THC-related products help align the mind and find its natural focus? My experience with this, it has been fruitful when my attention disorder has been associated to that bipolar side and helps me in various ways take from one hemisphere experience to another, therefore allowing self-teaching and more self-actualization.
Well, thank you very much. So THC is one of the active ingredients in cannabis. The other main active ingredient being cannabidiol, though of course there's many other things as well. THC is associated with the euphoric nature of cannabis. And what's happened since I was a student many years ago is that the proportion of THC in street cannabis has gone up markedly. So it used to be that it was 5 or 10%. So if you want to use an analogy with alcohol, that's a bit like a lager shandy, I suppose. It's now up to some places 70, 80 or even higher, 90%. And that's a bit like drinking tequila shots, really. So THC is powerful, it's powerfully euphoric. And I think the effects crucially depend on the dose and the duration, and also on the brain. So there's some evidence that people are more prone to the bad health effects of cannabis and THC if they start smoking before the age of 15, when the brain is obviously more plastic and developing than afterwards. There's no doubt that cannabis with high levels of THC are associated with psychosis. There's lots of work in London done by Professor Sir Robin Murray, Professor Marta DeForti, and others, showing that the cannabis causes psychosis, and also the higher the THC levels, the greater the risk. This isn't just psychosis, this is also mania. We looked at all the first episode psychosis services, which include the first episode of mania in London, and we found for both psychosis and mania there was an association with cannabis. What happened differently is that the people with mania, it tended to resolve after they stopped smoking. But it's a big problem. It seems to be a very difficult message to get across, that cannabis is bad for your mental health. It's probably bad for your cognition. I've certainly seen patients who smoked cannabis very heavily for many years, and who I think are quite cognitively impaired, really. Now, the point that the questioner makes is, are there some people within this overall circle of people who do badly who might do well? Well, we can't say that isn't true, and I've certainly had some patients who've said that very few, they feel better with cannabis. I wonder if that's partly because they're treating their need for cannabis, so that really is an issue. But I think in general, I'd advise most people to try and steer clear of cannabis, and also most other drugs of abuse. Now, one possible difference, and it's very early to say this, might be psychedelics like psilocybin. Our group here in Imperial, my colleagues in King's and others throughout the world have been looking at psychedelics for treatment-resistant depression. We're getting some very good results. 2 colleagues in the US, Scott Aronson in Maryland and Professor Trisupis in California, have done some studies in bipolar depression and found, with a small number, that people seem to do well. So I wouldn't rule out psychedelics as a possible treatment, but I'd need to see a lot more data first. But certainly with cannabis, I don't want to be puritanical about it, but I'm afraid I can't see circumstances in which I would think is good for your mental health.
Thank you for that. And what should relatives, romantic or family or friends do if their loved one is or has a diagnosis of bipolar affective disorder or is in an episode?
Well, I think one thing is, I think people and their significant others could if they're in the UK, could join Bipolar UK and get involved and learn about the disorder. I mean, I think we've seen a sea change in society with people being much more aware that it's not shameful, they shouldn't feel guilty about having a major mental disorder.
Nope.
And you know, I'm a big proponent of Bipolar UK. I was a trustee for many years. I'm still a clinical advisor, and I think the information and sharing is a very good thing. I think also it's good to have a plan. I mean, it's good to have a plan in advance of what would happen when someone becomes unwell. So this can go in line with early warning signs or relapse signature. I mean, you can include the significant other, the spouse, in that. And there can be an agreement that if they think they're going off, they get treatment and so on and so forth. There's a further iteration of this with advanced directive, where some people say they don't want particular treatments. I mean, I've got one patient who doesn't want particularly injections of old antipsychotics if she becomes manic, because that means, you know, that they've made her terribly depressed in the past. So I think looking at these things in the round, but it's information, communication, and having a plan is actually a very good thing. And also talking to other people. I mean, I've observed how powerfully therapeutic it is to feel you're not alone. For someone else to say, well, you know, I was like that and I thought this. We were in a psychoeducation group, and there was a young man who said he didn't want to take his meds because it was boring, and he didn't want to have bipolar disorder, and he didn't agree with the diagnosis, and this, that, and the other. And one of the other members of the group said, well, he was HIV positive, he took his PrEP and, you know, his preventative medicine. No one would deny that that was an important thing to do, but if you look at the consequence of uncontrolled bipolar disorder, it can be worse actually than uncontrolled HIV. And so he said, I take my preventative medicines for my HIV, why wouldn't I take them for my bipolar disorder? And that was much more powerful and impactful than anything I could say, because it was his lived experience speaking to the other person.
And people are, and it's doing away the stigma, right?
Yeah, sure.
So we'll take a pause again, Alan.
Okay.
Stay tuned for more questions. I've got some controversial topics and questions for Alan, so
Okay.
please don't miss the next part. But thank you, Alan, for
Thanks.
joining.